I thought I'd just kick off with a little bit of perspective in that I've been going to the Digital Health Conference and this conference, I think, for 5 or 6 years at CES. And there is finally, I think, a shift in the industry. And when I used to go to CES, I'd show up and there were a whole lot of, I'm going to sort of bag them as techies who had cool devices that were something to do with your health and wellness. And there were a whole lot of docs showed up on the other side, and they had needs, and the two were not communicating. And I think today we have begun to see a real movement where the medical field and the technology and connected health field have come together. And I see that in the movement from, because Zymedica's side is that we build devices, we design and build devices. Now we design and build connected devices, and connected devices are, they're pulling data and monitoring and so forth. We've seen a huge shift in the industry from payment, talking about payment, to talking about value. And then, of course, we've seen the movement over to things like robotics and telemedicine and assistive intelligence that is helping the docs out. So it feels genuinely like we've got to a point where there's a real dialogue going on. And this idea of the pyramid, I'm not sure it was a pyramid or a triangle, but the idea is that every technology that we see has, every idea and startup we see has a connected enabling technology. It has a reason to exist, a user need, and it has some sort of payment model. So with that, we're going to talk about those three elements, and I'm delighted to have Jeffrey, Ryan, and Akhil here today, who have different perspectives in the industry. So I wondered if you could just kick off, Akhil, and just in where you're coming from, and briefly what Gecko and CareTrax and Teva are all about.
Sure. So yeah, I'm basically wearing two hats right now. The one that you see on the board. I mean, my new role in Teva Pharmaceuticals in the last 8 months after the acquisition of Gecko Health. So prior to acquisition, Gecko Health build a platform for managing respiratory diseases. So we played both with the hardware and the software side. We were focusing on the software, on the building platform for chronic management for the patient themselves, for the patients, caregivers, doctors, and also giving different points for the payers and pharmaceutical industry in the end. And we built sensors to collect information from asthma and COPD inhalers. So this was the product. 8 months ago, we were acquired by Teva Pharmaceuticals, and now we keep building this platform for more than just respiratory diseases. This is my background.
Ryan Schaefer, I lead human-centered design for United Healthcare's Innovation Center of Excellence. And prior to joining United, I was designing consumer use medical devices. And our team is focused on how we connect with consumers. We spend a lot of time in homes, how we connect with providers, and how we can bring these two together to design solutions, mobile, app, web, digital, and in some cases devices where it makes sense. And we launch pilots, in-market pilots, to test and experiment with these to see if we can solve some of these complex challenges in the marketplace.
I'm Jeffrey Brewer, the CEO of Bigfoot Biomedical. We're developing an ecosystem of connected devices, glucose sensing, and insulin delivery to make it easier and safer and more cost-effective to deliver insulin. For those people whose lives are dependent upon insulin, my son included, who has type 1 diabetes, this is a problem that is by no means solved, and one that is very well attacked by technology, smart devices, connectivity, cloud systems, and so pulling a lot of pieces together in order to do decision support at early levels of products that are 510Ks, up to and including automation of insulin delivery, which is a Class 3 medical device.
So, Ahil, when you, as you were thinking out from the earlier stages, because the startup was what, 2 years ago or
4 years ago.
4 years ago. Yeah. What was the driver on that user side? So you had the beginnings of technology, but what was the user coming into the picture?
So my background is both on clinical and on the technology side. So I was a practicing physician for a couple of years, and also worked with different startups on building, mostly on the EMR side. So trying to build better engagement with the clinicians. When we came to Gecko Health, it was started as a personal story. Also in my family, we had a few asthma patients. My grandfather died from an asthma attack that could avoid it. We know that asthma is a disease that basically we have all the solutions. The drugs today are fantastic. Patient can be managed and maintained at home. This story with some other stories of the founders that came together, we really focused. We realized that there is a gap, and 4 or 5 years ago when we started, there was a huge gap in managing those patients, asthma and COPD. There was really completely disconnection between what we knew about the patient when they come to the clinic to what happened at home. And I think the same dissonance exists in other diseases, in chronic diseases. Mostly when the patient is just can see the doctor every 3 or 6 months, and we have no idea what's going on between those times. So we try to find solutions to see how we can bridge this gap. So very early on, we started with, Ryan said, meeting the patients and meeting them at home and see how they are managing the disease, treating themselves, actually using the devices that they have, the drugs that they used before, and try to find something that really connect all the different little gaps that we found. And the biggest one was just to understand when they're using the drugs. And we thought that this is one of the, if we find one thing that can really change the way we understand the disease, understand the patients, and try to help them later on the practice, was the idea of when they use, what caused them to use, and this is where we started. Trying to see if we can collect information about the drugs, collect information by the patients, and more passive information on their lifestyle, basically. So this is where we started.
So Ryan, United Health is the patient to patient, or is it how do you view that relationship?
Sure, great question. So as I mentioned, we do spend a lot of time talking to members. So we talk about them more as members, and when we talk to our clinician and provider partners, then we'll talk about them as patients. But really, as we immerse ourselves and walk in their shoes and understand what are the challenges that they face day to day, what is it that they're doing, what are their goals and their aspirations, what are they frustrated with, that's when we'll look for those opportunities. How can United Healthcare help connect the dots between what our members are trying to achieve, what physicians want our members to achieve, and how we can bring our data analytics capabilities to bear to create experiences. So in one particular case, we have a wearable solution where there are devices, a blood pressure cuff, a scale, an activity tracker, and then we bring in a coach via FaceTime. So it's the right time for the patient. We're watching the data feeds to help provide them real-time solutions so that they can modify their behavior. So it's almost just-in-time care and support brought from this United Healthcare ecosystem to really help drive change. And it's hard, but we're working diligently hand-in-hand with members and that the clinical providers and partners. We look for partners on a regular basis to understand where can we bring the right technology to the table, whatever it might be, whether it's an app, it's a device, it's an experience. And between those, we're helping move the needle on many fronts to make experiences better.
Well, you asked about the pyramid. So our pyramid is patients, providers, and payers. And those are the lenses which we put on everything that we do, because those are the three constituencies we need to be able to serve in order to create a valuable offering and a valuable business. One of the problems with the existing device solutions for insulin-dependent diabetes is that they were designed for a small number of doctors, the KOLs who are endocrinologists, not really for patients and not really with health economic outcomes anticipated. Those existing solutions, which were designed 20 years ago, have now been scaled up and tried to be delivered to a number of different environments in which they don't scale well and they don't deliver cost-effective outcomes. So we sort of went back to the beginning. The 4 founders of our organization have kids with type 1 diabetes, and one also has a wife. We have a lot of people who understand the patient and how they live with the disease, and it's a particularly pernicious disease in terms of the amount of decision-making and stress it places on the patient. Doctors, it's actually very challenging as well because they don't have the data on what their patients are doing, yet they have to give life-critical advice on the titration of this dangerous drug that patients are literally making decisions about giving all the time, and sometimes that ends up quite catastrophically, up to and including death. And the payers, there really was little concern given historically to the healthcare economic outcomes. So we really went back to the beginning and we said, what's going to work for the patients, the most possible patients, not just the ones treated by endocrinologists and high-end academic care centers like you'll experience here in San Francisco, where my child luckily had the good fortune to be treated, but really across the network where you have primary care providers treating most people with type 1 diabetes in this country today. What's the solution that plays in that environment? And then what are the health outcomes that actually are most demonstrable, tangible, and affectable within the context of a short time frame that payers are, by necessity, having to care about? It turns out there are some adverse outcomes that we're very focused on that can be measured in a short-term basis. That kind of perspective where you're constantly putting everything through the filters of patient, provider, payer, it's really the only way to develop solutions now that I think are going to actually be viable businesses and certainly are going to scale to solve problems. So it's something very focused we are on that. And in terms of the payers, we're actually going so far as to create financial models, modeling outcomes based on patient populations that we can go and take to payers and sit down with them and say, based on your data, the characteristics of your patients, here's what we would project that our solution would do. And we're willing to tie the outcomes to the cost of the solution as well.
So you're creating essentially a closed-loop system that has some inputs, but it is going to sort of kind of take care of itself.
No, unfortunately, that's not possible. I wish there were a plug-and-play solution. Yeah. It is a complex dialogue between patient and provider and system. And what we're trying to do is actually enable the things that computers do well, which is do a calculation every 5 minutes and actually generate an answer that's always correct. Computers do that really well. They remember to do things without being reminded. Patients are terrible at that. But occasionally, the components themselves, they're machines, so they will fail. And this is a dangerous drug. So part of it, the value that we're creating is to engage the patient in that dialogue, to debug any failures of insulin delivery or glucose measurements, and to actually help simplify the process of coordinating all these different devices, which today are literally sold by different companies. The top company in the space only sells 2 of about 5 different pieces you need in order to live with this disease. Yeah. It's very much on the patient, on the doctor, and not delivering healthcare outcomes.
So let's talk about money. There's value. There's a component here that as Teva was interested in the company that you started, the users, the patients are interested. There is a health component of that, but where's the money flow in the system, and what was the value that Teva saw?
This is a tough question.
Other than you're extremely good.
Yeah. So I'll start by Teva saw what many other pharma companies see right now, which is the need to provide more than just a drug. This is to start with. We see more and more companies today on the drug manufacturers that are trying to find additional services, more solutions that they can provide, and basically build a whole ecosystem around the patient. Teva is not unique, but Teva is definitely one of those companies that took actions and are willing to move forward, and this was part of the acquisition. Our solution that provide a full ecosystem for patients with asthma or COPD patients fit very well with this vision, and this is what part of the reason. Where the money is, it was less important in this point. It's very important in the long run, but our business model were very different from before the acquisition to what it might be now together with a pharma company. Before, I think it was very similar to some of the things that were mentioned here. We work directly with the large payers, IDN system that can see the value in prevent patient from deteriorate or find the patient before they reach the hospital, keeping the patient as to self-manage themselves at home as much as possible. We put the dollar amount on how much we believe we can save, and this was the kind of the basic cost of our system. We start to work with other systems also that see value in the database that we collect. So the data, besides the ability to help the provider to make better decisions, to help the disease management team to support the patient, the data itself can help us to better understand how patients use the medication, why patients stop using medication, understanding different questions around adherence and behavior that by itself has a unique value. And this is where we played.
So multi facets of value.
Absolutely. I mean, so we, as mentioned, we try to build a product that can serve all the different needs in the industry. And I thought that we understand pretty early where the industry is going. 4 years ago, we already started to offer a more value-based payment for the solution. We see this change happening now, and I think it was fascinating to see how in the last 4 years, from trying to pitch the concept to payers and other healthcare organizations, in the last 2 years, we start to see this inbound interest in such solutions. And there is actually, people are looking to fill those different gaps. So I think diabetes was one of the first disease area when we saw the solution for, I think, one was the 10, 15 years now, we already see those kind of ecosystems that build around those patients. But now we see that the payers start to look for every chronic disease to see how they can build this platform to support the patients and to try to prevent those patients from reaching to the next level of severity, how to support them in more than just the drugs, building wellness programs around them. So we see this change, and I think the question about what's the price for such services is starting to be more and more clear now.
Ryan, how do the economics work in the?
Well, I'll say as a designer, I've spent a lot more time with United Healthcare's healthcare economics team this year than I would have ever thought I would have in a digital connected space. But we have a great team across United Healthcare that's helping, as Jeffrey mentioned, when you can model what those costs could look like. We know there are pain points between the patient, the provider, and the costs. How can we design things that are right for that collection of individuals that we think we could address those costs and drive those costs down? And for partners that can come to us and start to sketch that out, we're willing to experiment with how could we do this in a better way. There's no shortage of areas for improvement. And if you can look at those cost drivers in a specific way and do controlled small experiments, then there's an opportunity for us to really improve and drive costs out of the system. And as Yehiel had mentioned, building ecosystems to deliver targeted care. United Healthcare has incredible analytics capabilities. And what we're doing now is looking at what are the members that need the help the most, and how can we bring that assistance to them when they need it, where they are, and how can we plug into providers and help connect those two. Right now there's some disconnect between patient and provider, and if we can help facilitate that conversation in a meaningful way, then we think it would be a win not only for our members, but for the entire system.
So on the member side, potentially better health, potentially driving costs down, are two value points.
Absolutely.
Yeah.
When you're talking about healthcare, you're talking about regulatory oversight, you're talking about people's health and well-being, and they obviously feel a little bit different about that than they do their average consumer gadgets. But these are businesses, and the goal of a business is to do something better at lower cost. And internalizing that and actually just wrestling with it, because we have scarce resources to allocate to healthcare across the economy, creates opportunities for partnership and leverage that I think we've scratched the surface on. Doctors think about the disease and how to treat a disease differently across the medical system. Payers think about it differently. Payers and doctors definitely don't think about it the same way, and patients resent everybody in the system for delivering them bad solutions. All that negativity is the result of some bad incentives and some overlooked opportunities for partnership in the past. And design, your bailiwick, is a big opportunity because the interfaces between all this stuff, whether you're talking about apps or hardware or just people and the processes they use to do their jobs, they're all broken. That's the fundamental problem, is that people don't communicate, they're not incentivized to work together, and you can't fix it all overnight for all the healthcare system, but in this particular disease space that we're focused on, we think we understand all the bad incentives, opportunities for aligning incentives, and we're basically bringing these parts together to create a better mousetrap.
So what would you say in all your different situations? What are the challenges? We saw a slide about dogma last time, about this is the way things are, this is how we've been doing it. But what have the challenges been as all pioneers? I'll call you a pioneer, not a startup at United Health, but you're pioneering something within United Health. What is the challenges that you come up against that you're like, okay, I got to move through this, and I've got to get them to see the light or get past this hurdle?
Well, certainly there's no shortages of challenges at United Healthcare or within the healthcare system. I think what I find the most is helping let go of where we were and where we came from. Hospital systems that were designed in the 50s, medical education that is very specific to if it's unknown or different and we don't have that clinical evidence yet, are we willing to take the risk and invest in it? Consumers that are starting to embrace this shift towards consumer-driven healthcare and the desire for the consumer to find a retail-like experience in the healthcare system that doesn't quite exist yet today. So again, using the design lens to bring people together to the table to say, let's work together to co-create solutions and really envision what the future of healthcare could be. And then let's apply that in a practical way in a pilot to experiment and see, does it work? We need to have the right perspective from the provider. We need the clinical evidence that will indicate this is based on good medical science. And we need healthcare systems to participate. We need good technology partners and payers to think differently. And United Healthcare is absolutely thinking differently as we look at the future and what it could be to solve these challenges.
Well, I would say that one of the challenges is that you have very uneven understanding of even the problems at the payer level. Like United is at the forefront of understanding how costs are absorbed by the system, where the inefficiencies are. And so you can have a dialogue with the United that you can't necessarily have with all payers. We've been doing blinded interviews with decision makers at health plans, and most of them validated our proposition that if you bundle things, that's going to be better than nickel and diming across a bunch of different charges. That if you actually make them more subscription-based rather than upfront commitments, it got to be amortized over time. Everyone likes that, but there were a couple, and one of them literally said, "Now I don't get this. Can I just buy today with my existing processes, even if I pay more, because I'm going to have to change my forms?" And literally, it was that silly that like any degree of change by this particular payer, he would rather continue to pay more and get the better product rather than pay less and get the better product by changing only incrementally the way they digest these expenses. And so that's real. And as you probably know, you guys are at the forefront of that, but there are a bunch of folks who literally are very resistant to change. And the market will catch up with them at some point. They'll either be out of business or they'll change. But that represents an impediment to delivering more value because the market is only evolving over time as the payers get smarter.
I think we said this is, in the end, we're trying to bring new solutions that the end users are now only in the process of learning how they can actually utilize the value out of them. We see more and more, as you said, there are some organizations that are more on the front of this change. We're still in the beginning of this curve of looking at solution that can be part of the value-based payment. We all trying to be part of this, but I still think that we see it mostly in the pilot level. So we see a lot of pilot, a lot of small interventions around the country that are trying to use those systems, but we didn't do the real change yet. So system that's based completely on on this payment system are still finding themselves, blocked, and it's very hard to see a real, penetration in this market yet. And I think it's a question to ask ourselves. How, the whole healthcare industry, if everybody gonna take along with this idea of value-based, how we actually gonna embrace more and more systems into it, because now we see there is, as part of this change, we see a lot of innovation, a lot of companies that are trying to be part of this. But in the end, there's not going to be a place to everybody. So I think, this is going to be another change that we'll start to see. Maybe some of the large companies will try to develop themselves. We see United trying to bring a lot of inside innovation that make it very hard for some of the small companies to get into this. So we are still in the beginning, although we feel like we are, already kind of part of this.
Now, one of the things that over the years in digital health has been the sort of fear of regulations. And so none of you have mentioned cyber. We're in connected health, we've got cybersecurity, we've got the FDA, we have a whole lot of different guidelines and regulations. How do those play into your individual businesses? Certainly because we've got two essentially drug.
We're a drug delivery platform.
You're a drug delivery
it's the same,
platform.
Same thing in terms of safety. It's,
yeah.
We're highly regulated and should be, because we're seeking to inform the decisions and in some cases the automation of delivery of a drug that can kill you. So it's appropriate that that's regulated. We're able to benefit from the fact that the patient advocacy efforts for the particular disease that we're trying to address have been very strong and have created some alignment at the FDA and some clear guidance as to the regulatory pathway for these systems. So the sort of NGO partnered with the private sector and informing for government how to think about risks and benefits for these technologies has been very helpful for us. And so we're in a good place with the FDA. The FDA is not the bottleneck here in terms of getting these new technologies to market. Now, the FDA is a very different place depending on who you're talking to, but for us, we've had a very productive dialogue, and they're very on top of what the opportunities are.
And did that dialogue start at the beginning?
Well, it started when I was the CEO of the Juvenile Diabetes Research Foundation,
okay.
And playing a very different role, which was a patient advocate. And it continued as a number of us who in our previous roles had dialogue with the FDA. They've identified this area, automated insulin delivery, as one where they want to see innovation and actually want to have a win in terms of working, not cutting us any corners or doing any favors, but in fact creating a dialogue and a partnership to do what makes sense for patients. And so we're very happy about that. The cybersecurity is going to be a very big issue. It's one of the things that when we bought an insulin pump platform and repurposed it for a connected system, we re-architected the security from the ground up. The Internet of Things and actually having that pump on a network where somebody could talk to it and influence it and dose this very dangerous drug into you. That's how my co-founder actually created his own artificial pancreas system by hacking into existing medical devices. So 50% of which are still completely insecure, and you could walk up behind somebody with a laptop and dose the entire storage of insulin into a person. It's what allowed my co-founder to create his own system for his wife and son. So it's about, I hope to God, nothing ever happens where somebody takes advantage of that and does harm to another. But just in the world we live in, that doesn't seem like a realistic expectation. There will be an event soon where a medical device gets hacked into and somebody gets hurt, purposefully or not, and then FDA's hair is going to be on fire. And the companies that have thought about this and designed for it and architected for it are going to be in a very different position than those that haven't.
Yeah. And
I don't do as much on the FDA side as I used to, but I certainly as a designer learned to embrace your regulatory team and look at those compliance and the FDA regulations not as barriers, but as opportunities to differentiate from your competition and to excel and go places where others can't. So if you have a good regulatory team, stay close to them. At United Healthcare, we take our members' data and privacy very seriously and data protection. And we also have conversations about the responsibility of being connected with a connected health ecosystem to our members in what's the right way to help nudge them along within changes to their behavior. How can we help them achieve their goals? How can we protect their information, their privacy, and they're not be intrusive in their day-to-day world. And so a good UX design can help with that.
Yeah.
And our data security teams on the back end can help make sure that we have secure systems at every touch point, whether it's an app, a device, or some other point of interaction.
Yeah, I mean, I think the FDA definitely changed for the benefit of innovation in the last couple of years. We see a more friendly FDA in the last year or two, especially when it comes to apps and consumer devices. The main problem that we have recently is more really on the privacy and data, the way we can share the data. We are also trying to build something that is very consumer approached, very much around the patient. So we do want to know as much as possible about the patient. We want to use this information in a meaningful way, but this is where exactly there is some barriers. So you want to protect the patient and you want to protect the data, but on the other way, you want to use it in a way that can, you can compare, you can show more information to the patient and the caregiver. So in this is the part where we are still finding ourselves a little bit with some frictions around it. We would love to see a little bit more kind of giving more responsibility to the end user, to the patient. So, the patient can, if the patient willing to take more responsibility of the information and make decisions around it,
right.
We would like to see this. We are still feeling like sometimes, regulator play a little bit more like a big brother on the sense of kind of, we don't give the patients the opportunity to make a decision. We are playing also the international game, so we are, need to play the same issues with different countries in Europe, and every country has their own requirements, and it's another barrier. You want, when you develop a system, you want it to be as similar as possible, so you can really support. So this is some of the the frictions we still have, but there are always ways to solve it. It's definitely more as a challenge than a barrier.
I'm going to put this out. Any questions from the audience?
It's impossible to see.
This one? Okay. Hi, I'm a healthcare journalist. You guys mentioned FDA a lot, so I'm wondering whether you think in terms of adoption by providers, would it actually be better if a digital health app be a FDA mobile medical app or a connected device that's regulated by the FDA? Would doctors and payers adopt it more easily? Thank you.
I think it depends. What's the application? What's the intended use? Are you assisting in helping people to improve exercise habits and diet? At one level, that's a certain level of regulatory scrutiny. In our case, we're assisting the delivery of a dangerous drug, which could have some significant adverse events associated with it if the system doesn't work. I think the way doctors are going to think about that and the amount of data or evidence they're going to want to see to know that that's something they're comfortable prescribing, the amount of evidence that the payers are going to want to see before they're going to standardize and recommend it to doctors and or pay for it. It's just going to depend on what the application is. So I'd say it just depends.
Yeah, I would agree with that completely. It really depends on the application. There are plenty of things that you can do on the consumer side of the fence, and there are plenty of things that you can do on the clinical side of the fence. And I think if you're going to make claims, then it should likely fall on the clinical side of the fence and go down the path of the FDA. If you're doing more lifestyle management and helping people change their path, perhaps that's a better fit for a consumer app.
What actually is tricky is when you're doing both, because we actually have a system which is regulated, some parts of it Class 3, some parts of it the MMDA, some parts of it are going to be Class 1, and some of which will be unregulated. And actually drawing the boundaries in the cloud or on the app on the phone is where it gets tricky.
Mm-hmm. And I think it's also very much a question of the business model, because with a regulated app that you have more claims you can try to get reimbursement for. It's the only way, basically. So if the business model need to have some reimbursement because you want to be part of a package that, being offered to the patients, you have to go this path. Otherwise, and you want to go much faster to the market, try to get the non-regulated path. So it's a lot about the question of business model is very relevant.
Yeah, and that's where bringing the three aspects together. What are you trying to do from the user's perspective, what's the business model, and how does the technology fit is where when there can be an awful lot more value on the FDA side. Sometimes you're protected through the FDA, but you have to rise to their standards. So that sort of planning, regulatory strategy is key from the get-go. I'm getting this down to, look at that, 9 seconds. We're happy to take another.
Yes, my name is Ron. I work for a foundation that support small startups, and we sponsored several digital health endeavors, which most of them failed. They proved to be clinically advantageous and providing better health for the patients, but it was extremely difficult to bring the payers to adopt the new technology. And what Jeffrey was mentioning about changing the forms, it sounds, I think, alarming, and I think we all are too optimistic about the digital health adaptation to, and I wonder what you think about it. It looks promising, but not
So I have a
reality.
A funny story that we always use, so I'm not going to name them, but one of the largest payers in the country, we tried to get some partnership with them, and the request was, I don't want the system. I mean, you can do whatever you need, find the patients. I don't need it. We have like a very nice dashboard that you can see the information about the patient in real time. Say, I don't want it. All I want is once a month, send me a fax with all the patients that are high risk. This is it. So I told him, we don't have a fax in the office.
But this is where I would say that a technologist perspective can be very unhelpful in the design process, because everybody just imagines apps and cloud systems and it's all available on the internet. And some doctors' offices aren't connected to the internet, or they're behind a firewall that makes it impossible to actually transmit. So we have actually designed a system that does include faxes when necessary. And I come from a very different sort of tech space where some people would just say that's against their religion. But that is what it requires to get a healthcare application in the system today, because you have to actually look on the ground, the environment in which it's going to live, and what are the tools available, what are the incentives people have. And if sending a fax is the best way to communicate that best leverages the clinician's time and attention, then we'll do it.
I have a somewhat radical prediction, which is that today, to develop a new device is incredibly expensive and takes a very long time. To take devices and connect them such that data can be moved back and forward, such that the experience can be improved, et cetera, is relatively much easier. And the incremental change we can put upon healthcare is much more. And I think it is going to wash across the industry we're seeing it in multiple places, is this idea of connecting all sorts of devices to something else will provide more value to the patient, to the healthcare system, to the provider. So I think it's coming any which way.
And I would just say, don't give up, be persistent.
Yeah.
Maybe they didn't fail. Maybe you learned what you needed to learn to rebuild and approach the next insurance company. And I'll say that insurance companies are changing. I'd like to think that United Healthcare is changing faster than others. But there are still challenges within that system. But be persistent and build that solid foundation, as we've been talking about this pyramid, and forge ahead.
Fantastic. Thank you, everyone.
Thank you.